you get to nerves that are the same length that go to the fingers, and that's sometimes when symptoms can appear in the hands. So this is kind of the length-dependent nature of neuropathy progression. So just some basics about what nerves are. I sort of think of them as electrical wires, essentially. They have a wire, which is the axon, which is this sort of blue thing running through here. And then they have insulation, which is the myelin sheath. So, so peripheral neuropathy from different causes can affect either the axon or the myelin sheath, or both. And when it's a process that affects purely the myelin sheath, we call it demyelinating neuropathy, where you start to see loss of this insulation around the nerves, but the underlying axon is intact. And in this case, you get slowing of the nerve impulses, but unless the demyelination gets severe, the nerve impulses still get to where they need to go. Axonal neuropathy, on the other hand, the myelin sheath, for the most part, is intact, but the underlying axon is degenerating. And this usually happens at the end of the axon and kind of works its way back over time. And this also gives rise to that length-dependent nature that I mentioned in the last slide. So I see all kinds of neuropathy in my clinic, but I focus mostly on genetic or inherited neuropathies. And so one of the questions is often asked of me, or I ask when I see someone, is whether this is more likely or not to be a genetically determined neuropathy or an inherited neuropathy, or from something that was sort of acquired in the course of life. And so the way I kind of try to sort this out is, one big component is family history, whether there are other people in the family, particularly first-degree relatives, meaning children or parents that have neuropathy. And then the age of onset is another big one. So most genetic inherited neuropathies occur before the age of 40, whereas idiopathic diabetic neuropathy generally occur later in life. And often, even if the symptoms don't become apparent earlier in life, there's often some signs that there was a neuropathy present even earlier. So if you dig in, you can, for someone that has an inherited neuropathy, you can often hear that maybe they were a little clumsier when they were children, they couldn't keep up with other kids, they were the last picked in sports, those kinds of things. But there are exceptions to these rules. There are kind of late onset forms of hereditary neuropathy that can come on after the age of 40. And then when we do an exam, we can look for changes in the way the feet look, which can occur in other neuropathies, but often occur very early for genetic neuropathies. And then it's other sort of typical things of all neuropathies: sensation loss, problems with balance, but in particular, a lot of atrophy of the muscles below the knees can be a sign of an inherited neuropathy. And then sometimes the EMG nerve conduction studies can have a particular signature that leads towards a diagnosis of a genetic neuropathy, but often there aren't really telltale signs. In the case of demyelinating neuropathy, sometimes there are things that can be really helpful to make a diagnosis of a genetic neuropathy.
We do something about that, John? Or...
Sorry, someone have a question?
I said you froze for a second, I think.
Oh, I did?
Well, it says your internet connection is unstable. Maybe,
oh, no.
Maybe I don't know.
I'm sorry. Yeah.
Sure.
Am I coming through okay now?
Yeah, you're fine now.
Sorry, I'm at my home and not as reliable as when I'm at my office.
Yeah.
Hopefully we'll get through okay. I bet my kids are probably watching a movie or something too. So things that can argue against a hereditary neuropathy: if the symptoms are really rapid in onset, if you have sort of a known reason otherwise, like diabetes, if there's a lot of asymmetry. And then it's really important, I think, in neuropathy in general, to look for other things that could cause the symptoms, a particular kind of pinching of nerves in the lower back and the lumbosacral spine. So most forms of inherited neuropathy are dominant, meaning that you only need one copy of the disease gene to get the neuropathy, and those usually are pretty obvious in families. So if a parent has it, then there's a 50% chance they'll pass it on to their children. There are recessive forms, meaning that you need a copy of the disease gene from both parents. And so those are a little harder to track through families. It's a little less likely that you see those. And then there are kind of more complicated genetic forms as well. And And then in some people, the genetic change occurs spontaneously in them and it's not present in their parents. So the lack of family history doesn't necessarily mean that something is not inherited. So, so the classifications of inherited neuropathy are pretty messy. So it's mostly named after these three people who coined the term Charcot-Marie tooth disease. And so this really is an umbrella term for now almost 100 different kinds of hereditary neuropathy. But it's broken into type 1, which is demyelinating neuropathy, and type 2, which is axonal. But then there are also more limited forms that only affect sensation or only affect the motor system. And then there's other, so CMT, Charcot-Marie tooth disease, is really reserved for conditions in which the only manifestation is neuropathy. But there are other conditions where there's kind of a complex mix of neuropathy plus other problems, either with the heart or other parts of the body. So there's lots of different genes that can cause neuropathy. So why do I study this? Why do people like me study this rather than idiopathic neuropathy, which is more common, or diabetic neuropathy, which is more common? So the first point is that CMT is actually not so uncommon. It's less common than the other kinds of neuropathy, but it's actually the most common inherited neurological condition. So among genetic neurological diseases, it's rare, or sorry, it's common. But the bigger point is that it's really kind of hard to study things like idiopathic neuropathy. I mean, it's hard to make the diagnosis. We don't know what the cause is. So it's really hard to know what we can do about it or why the nerves are unhealthy. Whereas with CMT and hereditary neuropathies, you know exactly what the cause is. You know it's one gene. And if you can try to understand what that gene's doing, that might help you understand what's happening in those patients and maybe lead to a treatment for them specifically. But it might also teach you something in general about what makes nerves healthy or unhealthy. And so that's why people like me do this. So I kind of think of genetic diseases as nature's experiment. And so what nature has done over time is test out which genes are important for nerve health. And the ones that are important for nerve health turn out to cause CMT. And this is the same kind of thing that's done with other diseases. So for example, ALS, Lou Gehrig's disease, or Alzheimer's disease, most of those are caused in ways that we don't understand. But in those diseases, about 10% are hereditary. And most of the research that's really uncovered how those diseases work and led to treatments or treatment opportunities has been by studying the genetic forms of the diseases rather than the non-genetic forms. And so another idea that comes from this is that just in general, we don't really have good ways to treat nerve damage in any way, whether it's in the nerves or the spinal cord or the brain. We kind of know some of the things that happen and cause death of neurons and brain cells, et cetera, but we don't really have any way to fix that. And so the hope is that studying CMT can also help people that have nerve problems beyond peripheral neuropathy. So there's, like I said earlier, about 100 different genes that have been identified to date, and each year we learn a few more. This is just a partial list of some of those. And there's genetic testing that is actually free through a couple of different companies now that looks at about 100 genes. And so when we suspect hereditary neuropathy, it's really nice. In the past 10 years, this genetic testing has become much more available, and it's pretty easy to test for these specific genes. Since we don't know every gene, we can't rule out that someone has an inherited neuropathy just from these genetic panels, but that it's getting better every year. But what we know when we look at this list of genes is that there's certain kind of pathways that keep popping up that seem to be really important for nerve health. And so this kind of reflects that peripheral neurons in particular, even compared to other nerve cells in the body, and certainly compared to other types of cells in the body, they're really unique. So the neurons of the peripheral system are really like nothing else. They can have axons that are 3 feet in length. To go from your lower back all the way to your toe is quite, and that's one cell that does that. So that's quite a distance. And so we often show pictures of nerves like this on the left, but the reality is that they're more like this on the right. So this is actually sort of a peripheral nerve drawn to scale that would be about 1 centimeter long. So even a really short nerve. but it has mostly this very long axon that would be stretched out. If we drew it more to scale, say the one that goes, a nerve that goes from your lower back all the way to your toe, it would look more like this, with the axon being doubled back over and over and over and over. And so you can imagine this is a very different kind of cell to take care of than a cell like this or another cell, like say in your skin. So this presents a lot of unique challenges. And one of the main challenges is that to be healthy, nerves have to move things back and forth from the end to the cell body and from the cell body out to the end of the axon. And this is called axonal transport. And this occurs along these tracks that are called microtubules. And so basically there are little motors that kind of walk along the microtubules and carry things in either direction. And this is really critical to nerve health. And partly of the way we know this is because these genes that control this axonal transport are really commonly implicated in CMT. So this is, again, another sort of picture of what a neuron looks like. And these are the different pathways and genes that have been implicated in CMT. But the ones I want to highlight are ones that are involved sort of in what I call the structure of the axon. So these microtubule tracks that I mentioned, and also movement of things along the microtubules. And so some of those genes here are shown in blue. Some of the ones in transport, these kind of motors are shown in blue here. And then the things that the motors actually move shown here. So it really highlights how important this movement is to the health of a peripheral nerve.
What does vesicle? What does vesicle mean? Just the blood vessel?
Vesicle is sort of just a general term for kind of a round piece of membrane inside a cell. So there's different, so all of these things here pictured, these round things, would be vesicles.
Okay.
And then the other major category is mitochondria-related genes. And so mitochondria are the energy-producing organelles of the neuron, or of all cells of the body. And neurons are really dependent on a high degree of energy to support all this electrical activity. And so mitochondria themselves, and also the things that move mitochondria around, are also implicated in hereditary neuropathy, and sort of by extension, other forms of neuropathy. So I'll just go through a couple of examples of how studying these different genes that cause CMT have started to give us a sense of other kinds of neuropathy and how they might be treated. So I mentioned these microtubules that are these tracks that things move on. And so microtubules can kind of get modified a number of different ways to make them work better, to make them more stable or less stable. And one of these modifications is called acetylation, and it kind of makes the microtubules work better in neurons. And through looking at animal models of CMT, so basically, if you introduce human gene mutations into mice or rats, you can kind of make them have neuropathy, and then you can study why they have neuropathy. And in doing that with a number of different types of inherited neuropathy animal models, they've seen that changes in the acetylation of these tubulin tracks, these microtubule tracks, are associated with inherited neuropathy. So there's something going on that affects the way these microtubules and axonal transport is working. And we sort of know a way to boost acetylation is through this gene HDAC6, which is, the name is not so important, but the important thing is that there are drugs that can actually manipulate this pathway and kind of counteract what happens in CMT. And so these HDAC6 inhibitor drugs have been tried in animal models. And what they've been shown is that if you inhibit this gene HDAC6 with one of these inhibitors, it can make the mice better if they have CMT2A or other forms of Charcot-Marie tooth disease. And then this has been extended to actually show that this same inhibitor that was sort of shown to work in CMT actually can help people that have chemotherapy-induced neuropathy, or sorry, animal models of chemotherapy-induced neuropathy. So this kind of suggests that what's happening in these animal models of CMT is similar to what happens with chemotherapy-induced injury to the nerves, and it might respond to the same kind of treatment. So the idea is that these might be useful in other conditions. And there's actually been some research recently showing that these HDAC6 inhibitors and this strategy might actually be beneficial in ALS as well. So another aspect of chemotherapy-induced neuropathy, so it's known that the chemotherapeutic agents that cause CIPN, chemotherapy-induced neuropathy, also affect these microtubule tracts. And so some of the agents that are really notorious for causing this kind of neuropathy, paclitaxel and vincristine, directly bind to these microtubules and interfere with how they're functioning. So there's a real connection between what these things seem to be doing and some of the forms of CMT that I mentioned. One of the big questions with CIPN is why some people get it and others don't. Most people don't. It's really hard to predict who's going to get CIPN.
What percentage of people who have chemo do develop neuropathy? Do we know that number?
I probably should know that number. I don't. It depends on the dose. The likelihood goes up the higher the dose goes, but I don't know.
Is Dr. Holt, hasn't he been working on studies of less toxic chemo that might not induce neuropathy as much or something?
He's been doing a lot of characterization of similar to an animal model of chemotherapy-induced neuropathy, where you give these agents that I mentioned to mice and rats at a dose that causes neuropathy, and he's done tests to try to figure out whether there are drugs or other things that can reduce the likelihood that they'll get neuropathy.
Right.
Great.
So one of the big questions is, why some people are susceptible and others aren't. And so one thing that's kind of interesting is that patients that have a particular type of CMT are really highly susceptible to CIPN. And then there's been studies to look for so this raises the idea that maybe there's something genetic, some kind of genetic risk factor. Maybe there's something in these people that a change in a gene that's not enough on its own to cause neuropathy, but then if you expose them to chemotherapy, then all of a sudden you get this, neuropathy that comes out. And so there's been studies to look at what kind of genes might impart risk of chemotherapy-induced neuropathy. And what's come from these is that there are a lot of the same genes that cause problems with the axons, just like CMT. And what's more, some of the genes, if you look at known genes that cause CMT, some of those seem to be risk factors as well. So there's changes in genes that cause CMT. Let me carefully say this. There are genes that are known to cause CMT when they're mutated in a certain way. But what was found is different changes in those genes that on their own aren't enough to cause neuropathy, but it then seemed to increase the risk of chemotherapy-induced neuropathy. So all this is to say is that there's, all these overlaps between what happens with genetic neuropathies and what might be sort of underlying the risk of developing idiopathic neuropathy or CIPN or other forms of neuropathy, diabetic neuropathy, for example. So the last example I'll give is related to this gene that I study a lot in the lab. It's called TRPV4. We call it TRPV4. And so this is a gene that's mutated in a type of CMT, type 2C, and also other forms of neuropathy. And it's unique in that it's an ion channel, which means it's basically something that sits on the surface of cells and lets things flow in and out of the cells. And the mutations that cause disease cause the channel to open up more than it should. And there's actually drugs that have already been identified and made by drug companies to try to close the channel, which is one reason we work on it, because we think this is it makes a lot of sense that these drugs might help the patients that have these mutations. And so it's a way to try to treat at least some subset of people that have inherited neuropathy. But what's also been shown is that these same drugs that block TRPV4 and we think might help these people that have mutations in TRPV4 actually also protect in chemotherapy-induced neuropathy. So without going into too much detail here, basically what these graphs show is that this lower bar here is if you give a mouse a chemotherapeutic agent to cause their nerve response to go down, essentially giving them neuropathy. If you also give a drug that blocks TRPV4, that response is sort of stays normal, and so it prevents the onset of the neuropathy. And so what we're studying is whether these TRPV4 blocking drugs might be helpful in other situations with nerves are injured. It's been shown that it might be beneficial in stroke, might be beneficial in traumatic brain injuries, traumatic spinal cord injury, and we're curious whether it might be helpful in kind of nerve injury, peripheral nerve injury situations. So hopefully that didn't take too long. Hopefully I got my point across that what we're finding with studying these inherited neuropathy genes is that we think there's overlap between what happens for genetic neuropathies and what happens for idiopathic and other kinds of neuropathies. And since it's really hard to study those neuropathies, but when we study these, the hope is that when we learn about therapeutic targets like HDAC6 or TRPV4, that someday these will also be useful for other conditions. And so these are just, examples of these two drugs that I mentioned that are kind of promising for very specific forms of neuropathy, but maybe someday we can kind of show that they're actually useful in a more general way to address some of the problems that are common between CMT and acquired diabetic neuropathy, idiopathic neuropathy, et cetera.
Were you able to apply for and get any grants from the defense legislation to support your research, or you're hoping to do that?
I didn't apply this year, but I will next year if they're doing the program again.
Great.
Many people in our department applied.
Good.
It was a really popular funding mechanism.
Excellent. Excellent. Pat, do you want to look at the chat? I only see the number 3. Do we just have 3 questions, or what do we have?
Actually, I do not have any questions identified in the chat.
Oh, really?
No.
Okay. Well, anyone want to raise a question? I guess you can use the under reaction, put up your hand. If you want to do that, put up your hand if you have a question. Roberta, do you have a question? Unmute yourself. Unmute.
Thank you. I always do that. Yeah, I did put 2 questions in this chat, but I think I sent it to Eleni.
Oh,
Okay.
So sorry about that. Yeah, I have question number 1 is I have idiopathic neuropathy. And I was wondering if different types of shoes would help or hinder, because what I'm feeling, and that's the only way I know how to express is, it's when I walk, I feel like I'm walking on clouds. So I'm not really balanced well. So would orthotics help? I find sneakers that are full of foam really just make me feel more unbalanced.
Yeah, I think probably what you're describing is maybe there's some numbness, but there's also a subset of nerves that their job is to give you a sense of where your joints are. It's called proprioception. And so not being able to feel if your foot moves up or down is a big reason why people get off balance with neuropathy. I don't know if that's the feeling you're describing, but I think if that's the case, probably the best thing to help your balance in that sensation is good ankle support, actually. Maybe not the most fashionable, but shoes that go a little higher up the ankle sometimes can help with that. It just keeps the ankle a little more in a stable position, and then there's less ability for you to kind of rock on your ankles without feeling it and become off balance.
Thank
does
you.
that answer your question, Roberta?
Yes, I did have another question, unless you want to have somebody
Okay,
ahead of me.
let's
I
go
have a
ahead and
question.
let
I have a
Pam
question.
ask her question, and then we'll get back to Roberta. Go ahead, Pam.
Thank you. Can you hear me?
Yes.
Okay. I'm 74, been pre-diabetic for about 8 years. Last A1C was 5.7. And I'm thin. But I don't know if necessarily if the pre-diabetes has caused my neuropathy. Is there any real percentage, any real value in determining the cause at this point? I've heard the saying, there's no point in having a test if knowing the results, would really affect what you're doing.
Yeah. Well, I guess if you've had kind of there's sort of a limited number of tests to look for kind of common causes of neuropathy. And then there's more tests that can be done, but they test for things that are really rare. And And so the recommendations generally are to sort of stop after sort of a first round of looking for causes if those are negative. I mean, I guess it's a complicated question. You're probably not going to find an answer that leads to a treatment, but if, I think there's a lot of peace of mind of sort of knowing what the cause is, right? Because then you can stop looking. So in that sense, you do use the information, but with that being said, if you've seen a neurologist that has looked for the common causes and the answer is that it's still unknown, it's idiopathic, then you can probably stop there, I think. Does that help answer your question?
Sure. Excellent. Thank you.
I think you bring up another interesting point, though. Some people have really bad diabetes and don't have neuropathy.
Yeah.
Some people have very mild diabetes and have neuropathy. And we think that's probably goes back to this idea of some sort of genetic risk, like in CIPN, that there's, there may be genetic changes underlying that aren't enough on their own to cause neuropathy, but some kind of combination of genetic risk is, some of my colleagues believe that idiopathic neuropathy is actually a really complicated genetic neuropathy.
Oh, okay. We have a question about, could the second Pfizer shot have caused my neuropathy? And we get this type of question at a lot of the groups. I think the concern for COVID and the implications. Yeah,
I mean, I've followed as much data as has been shared about the side effects. There was a little bit of a signal with the Johnson & Johnson vaccine that there might be an increased risk of what's called Guillain-Barré syndrome, which is a kind of it's sort of an inflammatory neuropathy that can come on with some other vaccines. It's known, there's not great definitive proof, but there seems to be an association with some of the flu vaccines that you can get this kind of neuropathy. And they saw a little bit of that kind of signal with the Johnson & Johnson, but to my knowledge, the mRNA ones, the Pfizer
Moderna.
and Moderna, people have looked really hard for evidence that they cause neuropathy, and it hasn't been convincing.
Okay, thank you.
It's really hard these days because these neuropathy, these kinds, like I mentioned, Guillain-Barré, GBS, they happen all the time. And usually we try to look back and see what might have caused them. But the trouble now is that everyone's getting vaccinated all the time. And so it's really easy to, the likelihood if you develop Guillain-Barré, the likelihood that, a vaccine was given recently is high. So it makes it hard to sort through.
Okay.
I advise everyone, all of my patients that have any kind of neuropathy, that the benefits to the vaccines outweigh the risks. And I haven't seen convincing evidence that the vaccines are causing nerve problems.
Thank you. That's helpful. We have a question. How do you feel about IVIG for small fiber peripheral neuropathy? I've been tested for autoimmune disorders and there is nothing definitive, but very painful.
Yeah. I feel pretty strongly that while people like me would like to have a treatment for this kind of neuropathy, that the studies so far haven't shown that IVIG is beneficial. I think it's possible that some subset of people with small fiber neuropathy might benefit from IVIG, but we don't know enough to figure out who that might be. And when we've tested it, not me, but it just hasn't shown a benefit. And it's not a benign treatment. It's not without risks. And so based on that, I don't recommend it.
Okay.
I know I've seen a lot of people with small fiber neuropathy, and it's really hard to deal with, and it's hard to have these conversations where we say I don't have anything to really try to fix the problem, because I know it's really hard to live with, but that's unfortunately where we are right now with what we know.
That leads to a general question about treatments in general. Do you have a comment about what treatments we can turn to that actually might help us?
It's unfortunately very limited. That's why I do the kind of research I do. We know probably the best treatment for neuropathy right now is exercise. So we always recommend daily exercise if possible, and a combination of something kind of to get the heart rate going and even some weight training. And that's pretty clear in studies in animals and studies in people that it does slow the progression of neuropathy regardless of what the source of the neuropathy is.
Mhm.
So that's the really only treatment that we can recommend right now. There's no supplement, there's no if you identify the cause and say it's B12 deficiency, you take B12 and it should at least stabilize, if not get better. But for most other kinds of neuropathy where there's not a clear cause, or at least not a cause that can be fixed, there's just very little to do to slow it down. It's mostly, as probably most of you know, comes down to managing symptoms. You know, the neuropathic pain medications, if pain is an issue, things to help with balance. If foot drop is a problem, there are things that can help with that, braces. But it's a pretty limited tool set to try to have an impact on the underlying neuropathy.
We have a specific question about your thinking on chiropractic treatment for neuropathy.
Well, neuropathy, if we're talking about a pure neuropathy, then I wouldn't expect chiropractic manipulation to help, because the problem is in the nerve itself out. So, you know, if you have, say, numbness in the feet, the problem is the nerve kind of out in the leg and in the foot, not in, you know, the lower back or the neck.
Mhm.
That being said, some people have a combination of lower back problems, you know, pinched nerves in the back, and neuropathy. And so there may be a benefit in that situation. I think, the full disclosure, neurologists in general tend to be a little skeptical of chiropractic manipulation. I think it's probably just a bias of having been in neurology residency where we see some of the bad things that happen. They're probably very rare, but the people that see them are people like me when we're residents. So we get a little scared off of chiropractic manipulation. But
Can I follow up with a question, your view of
Yeah.
the connection between spinal stenosis as a source of symptoms and neuropathy? I've been seeing Perry Richardson at GW, and the last time I saw him, he said, well, maybe your spinal stenosis ultimately might be the cause, you know, go to a neurosurgeon. So I consulted with two, and they basically said, yeah, you have bad spinal stenosis, but if you're feeling no radiating pain down your legs, which I'm not, you're feeling nothing in your back, don't bother, don't do any surgery. So, but is there overlapping symptoms between the two? I mean, logically in my head, it always seemed like things would come down from your lumbar, your spine, and go down your legs, and there'd be a connection. But I never got a clear word on that.
it can be tricky to sort out. You know, usually when there's pinching of nerves in the back, either so you can have pinching in around the whole spinal cord or as the nerve roots come out. But usually in both cases, there's some pain associated with it. But, you know, with neuropathy, you get weakness and numbness. You can get both with spinal cord problems. Usually the spinal cord issues tend to affect one side more than the other. And so the asymmetry can be a clue. Sometimes you can get some useful information to sort it out with an EMG. So with a pure spinal cord process, the pattern is different than with a peripheral neuropathy. And then with spinal stenosis, there's often a lot of fluctuation of symptoms depending on whether you're walking and what your posture is, if you're leaning over versus kind of extended. Sleep can, you know, change the position of the back in a way that can make symptoms worse with spinal stenosis. So there's a number of things that can kind of help sort it out, but neuropathy is common, back problems are common, and so it's not uncommon to see a bit of both. And it can be really hard to figure out how much is coming through either.
Over the years, a number of our people have had both PN and spinal stenosis. So
Yeah, I think that another big question though is if it is a little bit of both, having a big back surgery is a big deal. And, you know, if it's 10, 20% coming from the lower back, is that actually going to make a difference for your
Yeah.
quality of life to go through that big surgery? And without a really strong indication that the back is a major component of the problem, then it's probably best to steer away from a big surgery.
Right, right.
Okay. Susan, you have your hand raised.
Yes, hi. I was diagnosed a year ago, and my neurologist did genetic testing on a panel of 43 genes. I tested positive, I guess, or a defect in MME.
Mm.
And my father had neuropathy, but I'm mostly curious about something you mentioned earlier about muscular atrophy. And I guess I wasn't aware that that was associated with peripheral neuropathy, but I definitely have that. Not quite as dramatic as the photo in one of the first slides you had.
Yeah.
But my calf muscles are definitely atrophied.
Yeah. Yeah. So if the motor nerve that supplies the muscle degenerates, then the muscle will shrink. And that'll happen in any form of neuropathy if the nerves to the muscles are affected. It tends to be more pronounced with inherited neuropathy than other forms of neuropathy. And then particular diabetic neuropathy tends to affect sensation more than motor function. And so there's not a lot of muscle atrophy usually in diabetic neuropathy. So the MME gene is one that was discovered not too long ago, and it's a little bit of an outlier in that it seems like it's a very strong risk factor. So sometimes the changes are enough to cause neuropathy. Sometimes they just increase the probability that someone develops neuropathy, but it's not 100%. But it's also one that can cause later onset forms of neuropathy. So it kind of breaks the rule that I mentioned earlier about onset after the age of 40 is generally not inherited, but MME genetic changes can cause problems later in life. And there's a big range of how severe it is too.
Mm-hmm. Well, my symptoms actually started, many, many years ago. I just didn't know what it was.
Yeah.
But I was also given a nerve conduction study, and it determined the diagnosis, but also indicated that a nerve in the lower calf, the peroneal nerve, was dead. Is that likely due to the neuropathy or some other cause?
Yeah, so that's most likely due to the neuropathy. One point about the nerve conduction studies, EMG studies, when you say a nerve is dead, that probably I assume you're referring to when they stimulated, they didn't get a response.
Right.
So it doesn't mean that the whole nerve is dead, because we're stimulating nerves that are kind of buried under the skin. It's not a perfect test. So there can still be nerve function, but it's just not high enough to be detected with these kind of surface recordings. So it's often the case that, particularly with inherited neuropathy, that the numbers look worse than the patient does. So it's really hard to record sometimes, but the nerves are they're not perfectly healthy, but they're not completely gone either.
And this spastic gait, is that due to the neuropathy?
Say that again?
Spastic gait?
Usually not.
Spastic gait.
Spastic, yeah.
Spastic is usually not a feature of neuropathy. So that means kind of stiff. Usually with neuropathy, if anything, there's the joints are a little floppier than otherwise. So that sounds a little unusual.
Okay, well, I don't know if it's spastic or just very clumsy balance.
Okay.
Thank you.
Did you have is that the final question, Susan?
Yeah, that's fine. Thank you so much.
Okay. Roberta, going back to you, you said you had a second question, and we have two more in the chat then.
Yes, thank you. I was wondering if physical therapy would help neuropathy. And also I find when I massage my feet at night, it feels much better. And I have a problem with my toes are hard to bend as well. So when I massage the feet, it feels a little bit better. And are there exercises that you can do?
Yeah,
Thank
so
you.
physical therapy, I think physical therapy is best when there's a kind of specific question to address. I think if there's a particular, part of life or a particular movement or balance, something that they can focus on, I think it's helpful. Otherwise, I think you can kind of learn exercises to do a physical therapy, and then you can kind of do them on your own. But I think, as a way to help you be able to do more exercise, as I mentioned before, I think physical therapy can be really useful just to kind of find ways to exercise comfortably and safely. And then you were mentioning, I guess, the way your toes feel and the massage. I think it's interesting that everyone experiences at least the sensory part of neuropathy a little bit differently. I think some people have a lot of pain, some people have more numbness, and then some people say they don't have pain, but they have a lot of discomfort. It's not quite pain exactly, but it's weird. It's, constant awareness that you would rather be without. And it's, it doesn't really track with the type of neuropathy. And the other thing that I've seen is that everyone responds differently to medications. Some people like things like menthol or capsaicin, which are sort of like, it drives some people nuts. It makes the symptoms much worse, and other people find it soothing. So in some cases, sort of stimulating the nerves a little bit sort of settles them down. In some cases, it makes them much worse. So the massage in your case sounds like that stimulation is helpful, but for someone else, it might not be. But, what I think everyone kind of has to find what works for them.
I think we hear that at each of our group meetings. It's a highly individualized disease, and the response you need to take. Speaking of, we have a question of vitamin B6 as an issue. It's hard to find a multivitamin without it. Is there a level that you would feel comfortable with if you were using a multivitamin that is a maximum safe level of B6?
So I think the question comes from the fact that B6 has been identified as a cause of neuropathy. So if it's really, really low, we think it can cause neuropathy, but more commonly, if it's really, really high, it can definitely cause nerve problems. But that has to be like 10 times or more the normal limits. And so I don't know specific numbers, but I think for a normal B vitamin supplement, the amount of B6 should not be anywhere near enough to cause a B6 related neuropathy. It shouldn't get that high. So I think a typical, B vitamin supplement that you take at the normal doses should be totally fine. I don't have numbers to give exactly.
I remember Dr. Hoke did comment some years ago about Metanx, METANX, to treat diabetic PN, and said that its level of B6 was toxic or was too high. And he was concerned because the Neuropathy Association at that time, the predecessor to the foundation, was taking money from Metanx advertisements on its website. And he thought that was not right. Even the foundation now gets a lot of money from drug companies. So some of these drugs, I think you have to be careful. And the B6, I remember he specifically said Metanx, which was fairly popular. I haven't heard about it recently. You should be cautious about that one.
Yeah, I think that's why I say, I think, a B vitamin that has multiple different, a B complex, I guess is what I mean, that has sort of like the standard supplement, the B6 without extra doses would be fine.
Right.
Hi, this is Sharon. I'm the one that asked that question. And so I've been looking all over, and my favorite company that's been recommended by nutritionists, I mean, it has 235% of the daily vitamin, but it's still one of the least amount of B6 that I can find. So it's just interesting. And I guess I'm more sensitive to it because at one point I did test really high on the B6 level.
How high? Was it?
I can't remember, but it was like, I can't remember.
Yeah.
You were out of the range or above the range or something?
Yeah, like way above it.
It has to
And
be,
I was taking some magnesium that had some B6 in it, and I just assumed it was like a small amount that wasn't gonna cause problems. But then you kind of wonder what does cause problems.
yeah, it has to be like 10 times above the normal limit. But yeah, I guess, you raise a good point. You have to be a little careful.
What is the normal limit? Do you know what it is for B6? Is so much
Off the top of my head, I
Huh?
don't know. Off the top of my head, I don't.
Yeah, okay, well, we can find that out.
We can get back on that. We have a question about gua sha with neuropathy. Have you heard anything about that?
Sorry, what? Let me look.
Carol, would you like to elaborate?
I've gone to an acupuncturist, and here's my little thing. She said I should get, this is called a gua sha, and apparently with acupuncture, and you use it to rub your legs and your feet. And I guess it stimulates the nerves. And she says it's very helpful. She's had good results with it. So
Have you tried it? Have you tried it?
What's that?
Have you tried it yourself?
I've tried it, and I haven't noticed any difference one way or the other yet, but I haven't been doing it that long. So I'm,
Well, if we have the acupuncturist in February, we can ask him about that.
Yeah.
Yeah.
All right, then we have let me see, it is a comment about, does sensory SFPN develop into autonomic SFPN? How do we know? Please mute. Thank you. How do we know if it has developed into the autonomic type?
Yeah, so this is a question about small fiber peripheral neuropathy. So the small nerve fibers generally transmit sort of temperature, pain sensation, and also the autonomic functions that are mentioned here. So kind of the control of sweating, control of heart rate, control of the GI tract. And it's sort of like other kinds of neuropathy. Sometimes all of those things are affected, and sometimes some and not the others. And it's kind of hard to know, hard to predict in any given person. My own experience with autonomic neuropathy, small fiber neuropathy, is that it tends to stay, it's not a hard and fast rule, but it tends to kind of, however it starts and what it affects, it tends to stay that way. So someone who has pure small fiber neuropathy that doesn't affect strength over the years, I don't generally see that strength is affected. If the autonomic nervous system is not affected initially, I don't generally see that it becomes affected later. So it usually kind of stays in its own lane, however it manifests in a given person, it tends to stay that way over time. But the way we would tell is mostly by symptoms, by asking about the kinds of problems you can get if you have an autonomic neuropathy, like some of the things I mentioned.
Yeah, someone put into the chat, says according to NIH, for 51 plus, RDA 80B6, what does RDA stand for? Is 1.5 to 1.7
recommended daily allowance.
Recommended daily allowance.
Yeah, so 1.5 to 1.7, so that's kind of small. So if your thing is over 200%, it's probably more than that. You probably check the milligram dosage of it, Carol, whoever it was. It was Eleni, I guess. No, not Eleni. You didn't change your name. Sorry.
That's Sharon. Yeah.
Sharon, whatever. Check your dosage. If it's more than 1.7, then it could be a problem. And someone asked about gabapentin. That was the last question I see.
Yeah, sorry, I'll just say one other thing about the B6. What I was saying is, we don't think that a high B6 level is the cause of neuropathy unless the level we measure from the blood is 10 times the normal limit. So if you take a lot, mostly what you'll do is pee it out. So even if you took like 200 milligrams, it might take even more than that, much more than that, to actually raise your blood levels enough to kind of overwhelm your body's ability to just pee it out.
Right.
But I don't know how high that would be.
Anyone else have a final question? Because we should wrap this up soon.
Yes,
Laura,
we
Laura's
have-
a new person. What about
Steve,
Laura?
wait. Laura, go ahead, please.
Yes, Dr. McCray, I kind of got a strange thing. I say it's neuropathy, but I have just burning nerve pain. And exercise basically brings it on. I've been an exerciser all my life. And what has brought on the flare-ups was exercise. I went to a physical therapist. He gave me an exercise and it radiates from my lower back. And, it can go all over my body. And one pain doctor said, well, I don't think it's from this because you don't have it down your legs, but, right behind your back, it just starts there and it can radiate all over. And I can't tolerate meds. So I've been trying some alternate stuff and ice. I tend to, I can't handle heat. I would never be able to do a Tenzi or anything. So I haven't had the EMGs and all that because anything you do to me and activates it, I become like, the pain is unbelievable when it's flaring up really bad.
Mhm.
So, but they just go, we can't help you. We don't know. We don't know what's going on.
Have you had a skin biopsy?
No, I haven't. I haven't done that.
It sounds like, as someone who thinks about neuropathy, though, to try to rule in or rule out neuropathy, I would say an EMG, which sounds like would be very painful, but you probably wouldn't need to do very many nerves to get an answer. And then if that's normal, then a skin biopsy. So the skin biopsy looks at the small nerves to look for small fiber neuropathy, because the only way to really test the health of those is to take a piece of skin and look under a microscope.
Right.
So, and then if that's all normal, then you have to think about other potential causes besides neuropathy. But if it is neuropathy, then you can kind of focus in on the things that can treat the nerve pain and neuropathy.
I've always been hesitant. I know back in the late 80s when I had flare-ups, they wanted to do that. And I was in so much nerve pain. And the flare-ups usually left, but this one's been a 7 or 8 month one that hasn't gone away. And I remember asking them, will the pain get worse? And they said, well, it could. Will it go away? Well, most likely. And I always thought, well, what's the difference? What's my treatment going to be any different? When they do decide, that you have this or that. I mean, it seems to be there aren't that many options for us in treatment. So other than the peace of mind knowing what you have. Exactly.
Yeah.
We have one last question. Does alcohol intake exacerbate PN symptoms?
If you drink enough, alcohol on its own can cause neuropathy. It's usually mostly a sensory, often painful neuropathy. It usually takes a lot over a long time. And so kind of moderate to small amounts of alcohol intake are probably not going to make a peripheral neuropathy worse. But drinking multiple drinks a day, every day for years could probably have an impact.
What's your take?
Dr. McCray, the question on gabapentin wasn't really a comment, was question mark. Why haven't you mentioned gabapentin?
Why haven't I?
Right. Yeah, I wondered whether you don't consider it relevant to the discussion. I was so surprised.
Oh, no. So gabapentin, other neuropathic pain medicines definitely help with nerve pain in a lot of people. And so I prescribe them frequently for people that have uncomfortable nerve sensations. So they treat the symptoms. They're a good treatment for symptoms. What they don't do is keep the neuropathy from getting worse or make it better. So that's why I didn't mention them, I guess, maybe in whatever context it was.
Okay, understood. Thanks so much.
What about R-lipoic acid, alpha lipoic acid, to keep it steady? I've been taking that for about the whole time I've had neuropathy, 15 years now.
Yeah, I think like these other medicines can help with the nerve pain, but doesn't really change the health of the nerves.
Right.
Right. I think there is one more because she has asked it twice, so I will ask.
Okay.
I heard that PN affects our mitochondria and our speed of processing. Can you comment?
I mean,
Does it affect the metabolism?
neuropathy on its own shouldn't, so it's possible that you can develop neuropathy because of a problem with mitochondria. You know, it's one of the things that the inherited forms of neuropathy I mentioned, some of them are caused by mitochondrial problems, and other mitochondrial problems can cause lots of issues, but also neuropathy. So mitochondria are really important for nerve health, but having neuropathy doesn't necessarily harm the mitochondria. It's usually the other way around. A problem with mitochondria causes the nerves to be unhealthy. And so if there are kind of, you know, mental processing issues, I would say those are in addition to the neuropathy, or maybe the neuropathy is not causing those, but there may be something causing both. I don't know.
So I want to thank Dr. McCray very much for your time and your expertise. We really appreciate it. Hope we can maybe have you back later in the year or next year. You are our advisor. Periodically, if we get questions, we may send them to you, and at your convenience, you could get back to us. I think we've covered everything tonight. Please send me your email address. We'll have the acupuncturist person in February or April. And stay well, stay safe, stay sane, and above all, stay vertical if you can. Okay, thank you.
Everyone, you can save the chat by clicking on chat and the 3 dots, the ellipsis. You may save yours to your own computer. And I assume, Steve, have you saved it, please?
Well, it says, you're talking about the 3 dots next to the smiling face?
No, I'm sorry.
Where are the 3 dots to save it?
If you click on chat, it opens up
the word chat. The word chat. You mean on the bottom of the screen?
Yes, on the bottom of the screen, if you open your chat box, the very last message has 3 dots. If you right click on that, you can save your chat, and we'll be saving it. And I guess Eleni will be able to send it out along with the summary of the meeting.
Okay.
But it's steve.klitzman@gmail.com. If you want to contact Steve or send him your email, which would be very helpful.
It would be very helpful going forward. Thank you so much, everybody. Be well, stay vertical.
Thank you, Dr. McCray. Thank you, Steve.
Thanks.
Okay, great, thanks. Bye.
Bye.
Record.